I can answer questions now, or if that would work, or perhaps we
Yeah,
need, is that?
I think that will work. We have one question that is, I'll just read it out loud. Given how these molecules can produce challenging experiences, are there thoughts or data regarding how stable a patient should be in their substance use disorder for this type of therapy to be effective?
That's a great question. So the answer is no. I mean, we don't actually have that data, but there's a lot of kind of safeguards that we're trying to institute. So, for instance, on the study that I'm talking about with MDMA, we're only going to take people with opioid use disorder that are on methadone or buprenorphine, so they've been stabilized from before they had childbirth. Unfortunately, even when people are on those therapies, about 50% still relapse in the next 6 months. So we think it's very important to study, but we're using that as a criteria. We would do a similar criteria for opioid use disorder with ketamine. One of the more challenging ones that we're looking at trying to study is we're in the middle of a combined fentanyl and methamphetamine epidemic, is how long to have people off of methamphetamine. And the problem with methamphetamine is we don't have a methadone or buprenorphine. We don't have drugs to help stabilize people on there. So um, I think there we're probably going to be a situation of trying to have people that are off of them for a much shorter period of time, are probably a week or less. So that's going to be a challenge, I think, with methamphetamine that's different than exists with opioid use disorder. But for opioid use, we're trying to get people that are on medications.
Thank you for that. And can I ask you, with we have a huge meth, issue in New Mexico, and I'm a hospitalist and I take care of a lot of patients who come in with meth intoxication, and kind of trying to get them through their intoxication and then get them through they have withdrawals, and the only thing we really have is let's say benzos or some antipsychotics that we use to get them through. But it's just very difficult as a physician to feel that helplessness, in being able to treat your patient, and like, what's going to happen next? They're going to go right back and use, of course, and that's been one of my challenges, like thinking about even ketamine, just because it's been FDA approved. How do we um, create programs where we can maybe even administer the first dose of ketamine IM in-house, with, of course, trained, professionals at the bedside, um, and into the community, into outpatient clinics and so forth. Um,
Yeah, that's a great suggestion. There are studies like of those happening in with cocaine and ketamine at Columbia.
mm,
Um, and so they've used that basically people who've been in inpatient treatment. It's a little trickier doing it when someone's just there for a couple of days on an inpatient service, and I totally uh, sympathetic to the difficulties of dealing with the amphetamine epidemic. With pregnant women, it's predominantly opioid use disorder, but I think at this point, probably 3/4 of them have meth as well. And you're
mm,
right, when they quit, we bring them in to start methadone or buprenorphine, but they're immediately like basically sleep for 3 days till because they're stopping their methamphetamine as well.
mm.
So I think we're hoping that that would be that mixed polysubstance use area might do well with ketamine, because ketamine has been individually shown in small pilot studies to help opioid use and cocaine disorder. So that's the one we're trying to target here for polysubstance use.
Very interesting. Thank you for that. Yeah, the stimulant use disorders seem to be challenging, or maybe just because we haven't really looked at them in as much detail as we have with the opioids, for example.
Yeah, there's really a desperate need for pharmacological as well as psychotherapy treatment. I attended there is a National Institute of Drug Abuse Clinical Trials Network symposium on pharmacological uses. Both ketamine and psilocybin were felt to be very promising and innovative treatments, and so we actually have research proposals being worked on at UNM for both of those. For the ketamine for combined opioids and methamphetamine, and psilocybin alone for methamphetamine. So
I see.
hopefully we'll have some promising outcomes, but realistically, we're still a couple years down the line. As you can
Sure.
see, once you think about doing a study with Schedule One drugs, it takes about 2 years to actually be able to do it.
Yeah, absolutely. We have a couple more questions that I want to ask Dr. Leeman before you go. Um, from Charity, thank you, Dr. Leeman. Wonderful info. How should we advise patients to seek out these treatments if they're not readily available in their community?
Yeah. So unfortunately we don't really have, we're not comfortable recommending people, go to unlicensed therapists. I mean, that certainly is happening. I'm actually discouraging people from using these, recreationally where they don't have a safe envelope. So I think really the best thing for us to do is try to accelerate
Yeah.
the studies. Both we're optimistic that MDMA will be available by 2024. The PTSD studies are very strong. I was actually a therapist on the last PTSD study, so we're hoping that'll be there. But unfortunately, there's not. I don't have a good answer to that. Question.
And yeah, I've gotten that answer, that question from, nationally too, on a national platform. But with the change in legalization with Oregon and then decriminalization in Colorado, and I believe in New Mexico, we're also looking at the legality surrounding psilocybin specifically. What are your thoughts on that?
Yeah, I can address that. So there's a group called the New Mexico Psychedelic Society that's been working with the legislature drafting a bill. Their goal is sort of to be somewhere in between the medical use of psilocybin as a chemical and simply like a decriminalization, having people use. And so the idea is that they would license people to use the psilocybin mushrooms themselves. And that could be for different things. The things that I've heard been discussed, that is end of life anxiety.
Yeah.
I think there's a strong feeling that given how long the FDA process is and the promising results, some people would like that to be available sooner than 5 years from now. It's not going to help somebody who has a terminal illness to hear that in 5 years we're going to have a drug there. Um, I hope if that bill passes. I mean, I've been a medical advisor and I've talked to the legislature. I mean, one of our concerns here is making sure that we have things set up in a way that's as safe as possible. Have trained therapists that are involved. Yet trying to balance the issues of access. I don't think we know actually how this will all play out because what's happening on the state level is not happening on the federal level. So if New Mexico as a state allows therapeutic use of psilocybin for psilocybin mushrooms, I think there's a thought that the DEA will act similar to medical marijuana and not enforce the laws. But I don't know whether as a researcher I would be able to help by doing research on that, or if that's going to be not a possibility. Because I really think that if those bills, if we have one in New Mexico, what they have in Oregon, I think that there should be research studies that are going along with that, so we can see, is there benefit, is there harm?
Sure, 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 sure. No, thank you so much. And then there's a comment. I believe there's a psilocybin study for methamphetamine use disorder at the Portland, Oregon VA that is starting enrollment soon. And I believe that in this study, it's being done on an inpatient basis, and that patients have undergone detox prior to initiation of the study. I also believe there's significant integration done after the sessions.
Yeah, I'm familiar with that study. It's Dr. Chris Stauffer, who's a great researcher who's doing that. I believe I haven't actually read the protocol, but we had some phone calls together. I think they're looking at similar to what we talked about, maybe 5 to 7 days, which is what would be considered the detox for
For
that. And
methamphetamine.
that sounds like a great idea to keep people
Yeah.
in-house afterwards. That is what they were doing with the cocaine
Ah,
the cocaine. So that seems like a very smart way of doing this.
right. Right, right. And having that intense psychotherapy sessions before and after, I think it's extremely important.